Right, we're going to go straight on now with the rest of the morning, talking more about acute coronary artery disease. So the first talk is acute coronary syndrome, medical therapy, and PCI. There are 4 learning objectives. We're going to talk briefly about risk stratification, timing, antiplatelets, and then go through 2 special situations. You come and sit down at the front. Plenty of space over here. Okay, first, risk stratification. This is mostly for those who are sitting your knowledge-based exam. I'm going to have you look at this. This is the TIMI risk score. There are 2 risk scores that you'll need to know about for any test questions. This is a 7-point score over here. I won't read them out. You can see how old it is, but it continues to be relevant in 2020. The inflection point here is 2, or the cutoff is 2. So the world, that's the European guidelines and the American guidelines, continue to use this 2 or less as a means to stratify someone who may get away without having angiography, so an ischemia-guided approach. 3 or greater, you see the death MI and revascularization goes up sharply, justifies an ischemic approach in the eyes of the guidelines. The other scoring system is the GRACE score, a very big registry that was used to derive this score, and this is a more complex score. It's better discriminatory ability compared to the TIMI risk score, but it still has limitations. You'll see its various parameters over here. You can pull all these from the medical record. Now, there are 2 cut points that are used in the GRACE score. The cut point of 140, for those of you that like to dichotomize your patients, and we all like that these days, but 140, really big inflection point over here, 6% 6-month mortality. And the guidelines both in Europe and America say GRACE score of 140 or more, take these patients very seriously, primarily as to the urgency of angiography and revascularization rather than whether they should get angiography. So 140. The second cut point is 109. This is an area of debate. I understand that NICE is now going to use this as a means to define who should get angiography and who doesn't. So less than 109 maybe doesn't get routine angiography. I think that is a concern, and one of the reasons is the heavy weighting of age in the GRACE score. So if your patient is young, may have a little bit of ST depression and typical cardiac chest pain, their GRACE score may be 100, 102. So based on the NICE guidelines, they may not even get to cath lab. Whereas you and I both know this is the ideal person with few comorbidities who may gain the most over 1, 2, 10, 20 years from an early invasive approach. So GRACE focuses on 6 months and that 109 cut point, whereas someone who is elderly may have an elevation in troponin and will be above that cut point of 109, and according to the NICE guidelines may justify an angiogram. So it doesn't sit well with many people, so keep your eyes open for discussion on that. Several randomized trials over the years have compared an invasive approach with an ischemia-guided approach. Now, important to know that ischemia-guided doesn't just mean medical therapy and you're done. It means medical stabilization followed by a stress test for risk stratification, followed by angiography if the stress test is abnormal. So it's not the 2 polar opposites. It's routine angiography versus well, let's risk stratify them with a stress test approach. Regardless of that, all the trials in composite will favor an invasive routine approach for patients with a non-STEMI. You'll see the point estimate overall in this meta-analysis is 0.78 with 95% confidence intervals less than 1.0. Several more studies are underway. One trial recently done called the Verdict trial looked at timing and also confirmed an early invasive approach is beneficial. So beneficial for invasive in most patients. If you look at who has TIMI scores of 2 or less, it's very few of the patients that you guys are encountering. Most of the patients you're seeing are in the high-risk category and will get an invasive angiogram. So who can be managed without? The guidelines will tell you those with a TIMI score of 2 or less, without ST segment deviation and with negative biomarkers, or of course with patient preference. Now, as I said, this is an ischemia-guided approach for these low-risk patients. If they have recurrent symptoms, if they have mechanical problems, mitral regurgitation, LV dysfunction, all of these will favor an invasive approach. So for the bottom bottom line is that very few patients fulfill that category of can be managed without an invasive approach. The majority of patients will have an invasive approach. The question is, what about the timing of angiography? This is a hot area of investigation. I will say be careful what you wish for. Those of you who are in systems of care who are doing studies of a very early angiography will have to think how this might impact your lifestyle, your weekends, your workflow. That's a really important issue moving forward. Here is a question for you. If you can use your voting pads here. 77-year-old male, diabetic male, wakes with chest pressure at 4 a.m. He presents to the emergency department with chest pain, blood pressure and heart rate and respiratory rate, Gallop rhythm. You can read them all there. It's a high-risk patient. There is ST segment depression, some pulmonary edema, and an elevation of troponin T. Based on the current European guidelines, angiography is indicated. Yes, it is. We'll agree on that. But timing, is it immediate? Is it early, less than 24 hours? Or is it can wait till 72 hours? Okay, poll is open. And I'm going to go through this relatively quickly. Let's see what you've voted for here. Do I just click next here? Here we go. Can we go back? Okay, so very few of you said late angiography, and that's very fair. The question is immediate or early. Well, let's look at the studies that have been done. The studies have been done, there have been several, including, I think, one that's underway in the UK right now. This is the timing of angiography in these studies. And in blue, the patients who are randomized early, you'll see most of the earlies is in sort of 12 hours or less. So this is, you know, really think about your systems of care. How often are you able to get someone that comes in at 6 p.m. to have an angiogram within 3 or 4 hours? It's not an easy thing to do. Versus late, and late is really quite late. This is more typical in some parts of the world where patients come in on Friday will not get to a lab till Monday. So these are the studies and the timing, and the bottom line is that patients who are higher risk, for example, a GRACE score of 140 or more, do the best with an early approach. Routinely across the board, there's very little to say early invasive angiography is beneficial in everyone, but those who are higher risk, it makes sense to go early. And that makes sense, right? It's intuitive. If you've got higher risk features, you're at higher risk of acute deterioration if you're watched with medical therapy alone. The VERDICT trial that was published last year in Europe shows that too. It's the high risk patients with GRACE of 140 or more that do the best with an early invasive approach. So here's the bottom line for your exams. Immediate angiography, so less than 2 hours, those who are in very high risk, so unstable, refractory pain, VTAC, mechanical complications, that makes a lot of sense. Class 1, level of evidence C. Those who should get an angiogram early, within 24 hours, if you've got an established acute coronary syndrome diagnosis with dynamic ECG changes and that GRACE cut point of 140. And the remaining who are intermediate risk should get an angiogram, but there's no rush to do that. So in most systems of care, that is achievable. So for the answer to the question, I think a third of you got this right. Based on the European guidelines, and that's what I've addressed all these questions on, the answer would be an immediate angiogram. Look at the patient. He's in cardiogenic shock. He's having ongoing chest pain, ECG changes, and troponin elevation with pulmonary edema. Right? These are all the high-risk features. The only thing that's not there is ventricular tachycardia. So this patient is at high risk of being left alone and should have an angiogram. Third point here, antiplatelet therapy. The guidelines will say that dual antiplatelet therapy is a class 1 recommendation, aspirin for all of these patients, then your choice of the 3 primary antiplatelet second drugs. The ESC guidelines favor ticagrelor. We at Mayo have switched back to favoring clopidogrel. Ticagrelor is favored by the European guidelines, and prasugrel is favored only after the angiogram defines the anatomy. Question always comes up about intravenous drugs, intravenous GP2B3A inhibitors. Here's what you need to remember. There is no indication for the upstream use, that is a routine use of 2B3A inhibitors, your tarafibans, your Riopros, before they come to cath lab. No routine upstream 2B3A because the studies have shown no reduction in death or reinfarction, but a clear increase in bleeding with routine use of 2B3A inhibitors. Make sense? Okay, antiplatelet drugs, we're not going to go through all of these. There's just a few points to mention. I suspect you all know this. Ticagrelor is very short-acting. It works within 30 minutes, and therefore we know it gets out of your system very early. So it's twice a day, 90 milligrams twice a day over here. Prasugrel is a prodrug and is not limited by metabolization. Here's a question for you. 77-year-old female presents 3 days after a prolonged bout of chest pain. She feels well. Exam is normal. Troponin is elevated. There are some T-wave changes. She has an angiogram showing occlusion of a branch vessel with some atherosclerosis elsewhere. The decision is made to manage her medically. What antiplatelet regimen do you and the guidelines recommend? Aspirin alone? 1 month of dual antiplatelet therapy, 6 months, or 12 months? So she's not had a stent placed, but she has had an acute coronary syndrome and non-ST elevation myocardial infarction. Okay. Fantastic. So this is great. I tried to catch you out. You're way too smart for me over here. I tried to catch you out by the absence of a stent, but the learning point here is that dual antiplatelet therapy is for the patient and not for the stent. We've learned from the CURE trial many years ago now, and Trilogy and more, that 12 months of antiplatelet therapy is beneficial because it reduces recurrent events, not just in the infarct vessel. There is something about patients with non-STEMI, they're systemically hot, unwell, maybe multiple ruptured plaques, that we know that second antiplatelet drug will be beneficial at reducing recurrent events. Longer than 1 year? Why not longer than 1 year? Because the trials haven't been done. CURE was 1 year, Trilogy was 1 year. So we don't know about longer dual antiplatelet therapy in ACS in particular. There's a more recent study pragmatically saying, listen, an awful lot of the patients that we're seeing are both high ischemic risk and high bleeding risk. So think of the patients you see in practice. They're elderly, they are bleeding, they've had gastric ulcer disease, they've got renal disease. And these studies have shown that patients who are at high bleeding risk, it is okay to reduce the duration of dual antiplatelet therapy to 6 months, particularly if their bleeding score is high. Okay. Here's another question for you. A 56-year-old female receives a drug-eluting stent to the mid-right coronary artery, is dismissed on aspirin, ticagrelor, and atorvastatin. She has mild residual disease and returns to see you a week later in the office because of unremitting dyspnea. She looks well, exam and echo are normal, and as is her ECG. What is your next step? So she's had a non-STEMI. Do you repeat an echo, pulmonary function studies, angiogram, multiple ruptured plaques, right? Or something else? Okay, we'll give you a moment or so to vote on this. Hands up who said other. And what is the other? Oh, fantastic. Very, very good. So one extra piece of information per drug, ticagrelor. Breathlessness in 14%. Gosh, it seems like more than that when I see my patients on ticagrelor, but this is what the randomized placebo-controlled trials tell us, 14% or more. And I can tell you, because we're less used to ticagrelor in the US, you wouldn't imagine the investigations that some of these patients undergo. They have a repeat angiogram, blood test, pulmonary function test, goodness knows what, before someone twigs, gosh, it's the ticagrelor. One extra piece of information on prasugrel you'll need to know for your exam, that there are 3 categories of patients that should not get prasugrel. Those that had a prior stroke TIA. The randomized trials show that this subgroup had both higher ischemic risk and higher bleeding risk if they were on prasugrel. Patients who were elderly or had a low BMI had a higher bleeding risk but a lower ischemic risk, and the net effect was neutral with prasugrel. Nonetheless, we recommend that it's not used in these 3 subgroups. Someone who has clopidogrel, their risk of a rash is probably about 0.2%. So I suspect you've all seen, the odd patient with a clopidogrel rash. A few years ago, when we only had clopidogrel, it was a real struggle as to how to manage these patients. Now we have these other 2 drugs. Who is going to switch to prasugrel? Who is going to switch to ticagrelor? Very good. The answer is to switch to ticagrelor because prasugrel and clopidogrel, there's cross-reactivity. You may make a rash worse if you switch from clopidogrel to prasugrel. The answer is to switch to ticagrelor. Now, this is a common problem, right? Patients who have atrial fibrillation, who have an independent indication for formal anticoagulation, who've then had an acute coronary syndrome and have a stent placed. What to do with the patient who has independent indications for anticoagulation and dual antiplatelet therapy? There have been 4 studies that have looked at this over the last 3 years. I think the most important is this trial, the Augustus trial, and I do want to spend a moment or two on this trial. It basically is part of a theme. The theme will come through, and I'll show you the meta-analysis at the end. But this is important for practice and for your exam. But we see these patients all the time, right? These patients who are in AFib, who have a PCI. So here's the Augustus trial design. Let's go through this. 4,600 patients, the majority of whom had an acute coronary syndrome, all of whom had atrial fibrillation. There's a two-part randomization. The first part was open label, so you know, and the patients knew if they were on warfarin or if they were on apixaban, plus a P2Y12 inhibitor, and the vast majority of these were clopidogrel. Some were on ticagrelor and prasugrel, mostly clopidogrel. Then these patients were randomized in a blinded manner, a double-blinded manner, to either aspirin or placebo. So some patients were on triple therapy, warfarin plus P2Y12 plus aspirin, or apixaban. Others were on dual therapy, this plus placebo, or this plus placebo. So digest that for a moment. It's a complex design, but an awful lot of good information can come out of a trial like this. So here's the hard findings over here. Major bleeding, apixaban was superior to warfarin. Number needed to treat of 24, and that number needed to treat may go down the longer we go on after this study is complete. Death or hospitalization, again, apixaban superior to the VKA. Number needs to treat, impressive at 25. Ischemic events, no difference. Bleeding. More bleeding in patients who were on aspirin than placebo. So these were triple therapy patients, but no difference in hospitalization rates between aspirin and placebo, and no difference in ischemic events. I will say there was a little signal for higher stent thrombosis in the first 30 days in patients who were on placebo in Augustus. There's a little pause for thought. The other aside is that the mean duration of aspirin was 6 days before they were randomized. So pretty much all patients had some aspirin on board. But don't get obsessed with that stent thrombosis risk. The absolute risk was still extremely low. Okay, so what's our bottom line finding? And this is a meta-analysis of those 4 studies that I mentioned, Augustus being the big one. This supports the use of dual therapy. We should really not be thinking of triple therapy in most of our patients. The vast majority of patients will do well with dual therapy. If you have to choose between a DOAC and warfarin in an exam, the answer is DOAC based on Augustus and this meta-analysis. The combination of warfarin and dual antiplatelet therapy is the worst of all worlds, highest risk of bleeding with no benefit in ischemia. And there will be more tomorrow. Dr. Cohen is going to come and discuss this, so I'm going to leave further discussion to him. Okay. 4th point here, there's some special circumstance. Here's a different case, an 82-year-old female with dyspnea, atrial fibrillation, some ST depression, and a small elevation in cardiac troponin T. I'm showing you here a chronic total occlusion of the mid-LAD as a stent here with well-established collaterals. What's the diagnosis here? Exactly, a type 2 myocardial infarction, supply-demand mismatch. Who is seeing more type 2 MI now than a few years ago, right? We all are. I think it's important, and we've all been guilty of this, of getting the nomenclature wrong. To have a type 2 MI, you have to have either symptoms or objective evidence of ischemia, so ST depression, new regionals, something like that, a PET scan abnormality. If you're septic with a high troponin, or if you have renal dysfunction with a high troponin, that's classified as myocardial injury. That's not type 2 MI. So moving forward, I'd encourage you to use the 4th universal definition, and type 2 MI should be confined to the diagnosis where there are symptoms or objective evidence of ischemia. There are several, it's a very hot area. There are several studies. This is ours recently. I'm showing you this for 2 reasons. One is, this is Olmsted County. This is an epidemiologic study similar to Framingham. This is not just a cohort of hospitals. This is all patients in the community who had a troponin check that was even borderline elevated, were classified into type 1, type 2, and injury. And look at the rate of type 1 MI. Every year it's falling. The rate of type 2 MI actually hasn't changed much over the years, but as a proportion, it's now about 50% of all MIs that we're seeing. If I showed you myocardial injury, the septic patients, the renal, that'd be way up here. And these are most of the people you're seeing. But the true type 2 MI, they're not that many, but they are a big proportion of who we're seeing. Here's the summary of one of the studies that really fits in the theme of all of the type 2 MI studies, that they have a high mortality due to early and non-cardiovascular death, similar rates of cardiovascular mortality to type 1 MI. They do have a high risk of recurrent type 2 MI, and we can now risk stratify by the cause of type 2 MI. So here you can see if patients who had an arrhythmic generated type 2 MI did better than those who had blood loss, hypotension or hypoxia, and that kind of intuitively makes sense. The final point, special circumstances, a non-STEMI in a younger female. What am I getting at here? Spontaneous coronary artery dissection. I'm going to ask you a question here. I'm going to have you look at these three scenarios, case 1, case 2, case 3, and the question is going to be which is scarred. You're going to have 4 options. It's going to be case 1, case 2, case 3, or all of the above. All right. Case 1, case 2, case 3, or all of the above. All right, let's see. Okay, very good. So as I look at the numbers here, 95% of you are wrong, which is great. Hands up those who said case 3. Okay, you guys are right. This is spontaneous dissection over here, and this is the point I want to stress. It's fantastic that you're all hearing about spontaneous dissection, but it's not the cause of MI in every young female. When you see isolated proximal LAD disease, as in this pregnant female, think atherosclerosis. This was an atherosclerotic lesion. This case 1 is interesting. She presented here, and if you zoom in, you'll see a filling defect in the subtuse marginal. If you see intraluminal thrombus on a coronary angiogram, it is not spontaneous coronary artery dissection. Take it to the bank. This is a fact. Intraluminal thrombus is not scarred. And this patient actually had intracardiac thrombus from a DVT across a shunt. And I want to stress this because we have amazing treatment for atherosclerosis. We have amazing treatment for thrombus. We anticoagulate, but we don't have the greatest of treatments for SCAD. So don't lose out on the opportunity to make a diagnosis of a non-SCAD condition. So just briefly on spontaneous dissection, it is primarily a condition of intramural hematoma. You see this is bleeding in the vessel wall causing compressive narrowing of the vessel over here. There is no atherosclerosis. This is a left main in someone who died bleeding in the left main media with no atherosclerosis over here. Conventionally, it's managed conservatively because we know it will heal in most cases. What do we mean by conservative therapy? Single antiplatelet therapy, beta blockers which may reduce the risk of recurrence, and we avoid statin if the lipids are normal because there's a signal for a higher risk of recurrent events. I want to stress that when you manage these patients conservatively, you should watch them in-house for a longer period of time because there is a risk of early extension. It's a dynamic process. In fact, this is case 3, the one that was a spontaneous dissection. She was managed conservatively, but a few days later, after she'd gone home, she came back with extension of the spontaneous dissection. So she had a big anterior myocardial infarction. She survived after coronary bypass surgery. 15% risk of deterioration in conservatively managed SCAD patients. Please remember that. So to summarize over here, I won't read through all of this, but this is all you need to remember for your knowledge-based exam. Low-risk patients can be stress tested for risk stratified. The vast majority of people you're seeing will get an angiogram. Timing depends on their clinical risk. The GRACE score of 140 is a good dichotomizer. Dual antiplatelet therapy for 12 months unless they are high bleeding risk. Okay.